Good afternoon to all the dignitaries in the dais and all the people which are present in the audience. I shall be presenting my talk on angle closure glaucoma and discussing the management of acute angle closure crisis. This quote has been taken from an ancient Chinese text, which means if there is free flow, there is no pain, and if there is pain, there is lack of free flow. And this holds so very true for our glaucomas. Angle closure is defined by the presence of iridotrabecular contact, which may be synachial or appositional, primary or secondary. Ethnic background is one of the key factors in determining susceptibility to primary angle closure. It is more common in people of Asian descent, and the other demographic factors are female gender, older age, and the presence of a first-degree relative in the family. And then the anatomical factors are hyperopia, thickened lens, short axial lens, shallow anterior chamber. The other precipitating factors can be emotional stress, dim illumination, mydriasis, intense meiosis, and use of certain drugs. Then the predominant mechanism, which is found in about 75% of the cases, is a pupillary block mechanism, in which the flow of aqueous is impeded from the posterior chamber through the pupil to the anterior chamber, and the pressure in the posterior chamber becomes higher than that in the anterior chamber, and iris bows forward to lie over the trabecular meshwork. Then there can be anomalies at the level of the lens also. There are changes in the shape or increased size of the crystalline lens with advancing age in predisposed eyes with smaller anterior segment. Like this patient who presented to us with acute angle closure crisis, and after lowering the intraocular pressure, when we did the anterior segment OCT for this patient, we found the lens vault in right eye was 1,225 microns, and in the left eye it was 1,027 microns. So for this patient, we did a clear lens extraction with PCIL implantation, and the patient is now doing very well without medications and having open angles. There can be anomalies at the level of iris or ciliary body also. These are the result of variations in the iris and ciliary body anatomy, which include a thicker iris, a more anterior iris insertion, and a more anterior ciliary body position. Then there can be anomalies which may be posterior to the lens, which may occur following trabeculectomy, lens extraction, laser iridotomy, and other surgical procedures. There's a classification system which has been proposed by the international glaucoma specialists, which includes the three terminologies, that is PACS, PAC, and PACG. PACS is 3 or more quadrants of ITC, normal intraocular pressure, no PAS, and no evidence of GON. And PAC is iridotrabecular contact, resulting in raised intraocular pressure and or peripheral anterior synechia. And PACG includes all these, but with glaucomatous optic neuropathy. So what we find over here is that the most crucial thing is a darkroom dynamic gonioscopy, and that should be the standard of examination. These patients normally present with acute, intermittent, or chronic, and now I shall be talking about acute angle closure crisis, in which the patients usually present with eye pain, headache, blurred vision, colored halos around light, nausea and vomiting, injection of the cornea and injection of the conjunctiva, cloudy cornea, mid-dilated pupil fixed, very high IOP in the range of 50 to 60, and iris Bombay. The sequelae may be in the form of sectoral iris atrophy, glaucom flecken, peripheral anterior synecdoche, pigment deposition of the iris and cornea, disc hyperemia, disc pallor, and cupping. These are the sequelae which we can see in the form of iris spiraling and several patches of optic atrophy, iris atrophy. So coming down to the management of acute angle closure crisis, which rests on 3 tenets, that is decreased aqueous humor production, reopening the angle, and reducing the inflammation. For decreasing aqueous humor production, we can do topical therapy in the form of beta blockers or alpha-2 agonists, and systemic therapy like IV or oral acetazolamide or hyperosmotic agents. For reopening the angle, we can use pilocarpine 2% pharmacologically, and mechanically it can be done by corneal indentation with a 4-mirror gonio lens or simple thumb pressure, or we can also consider clear corneal paracentesis, and then topical steroids can be used for reducing the inflammation. After the pressure has come down to lower 30s or higher 20s, then we can think of doing iris procedures in the form of iridotomy, iridectomy, or iridoplasty. And also remember prophylactic iridotomy in the other eye. Prophylactic laser iridotomy can be done in the cases of elevated IOP with appositional closure, greater than or equal to 22 and 70 degrees of apposition, narrow angle with PAS, history of AACG in the fellow eye, and iridotomy in the fellow eye. Now, a word about Eagle study. There is evidence that clear lens extraction may be superior to iridotomy, especially in Asian populations. Randomized comparison of iridotomy versus clear lens extraction in patients with primary angle closure and primary angle closure glaucoma was done. There were 419 patients at 30 centers in 5 countries. And those who were assigned to phacoemulsification, they had better quality of life indices, lower intraocular pressure, and far fewer medications. So it has been seen that clear lens extraction showed greater efficacy and was far more cost-effective than laser peripheral iridotomy and should be considered as an option for first-line treatment. So the take-home points are gonioscopy is indispensable, and this technique should be learned and mastered and be done as a part of routine eye exam. ASOCT measurements and UBM, like angles, angle lens vault, and ACD, offer newer methods to evaluate and treat glaucoma. Prophylactic laser iridotomy to be done in all PACS cases, and Eagle study offers compelling evidence in favor of clear lens extraction and can be considered as a first-line treatment for maintenance of quality of life parameters in PACG cases. However, each case has to be done on its individual merit. Thank you.